Okay, before we just a quick point before we move on, and that is I understand that some colleagues are having problems with Teams and it's a bit glitchy on vision, if not on sound. If that's the case, then I apologise, and I would just ask that people bear with us and see if we can work through that. So let's move on to the routine part of the agenda. Before we start properly, it's important, I think, that I welcome 3 new faces around the virtual board table this morning. First, we've got a new non-executive director in Dr. Sarah Whiteman. Sarah, welcome. Very pleased to have you on the board. I hope your first board meeting doesn't put you off and make you choose to go and do something else instead. And 2 associate non-executive directors. These are the first associate non-direct. I'm having real trouble stringing a sentence together this morning. These are the first associate non-executive directors that LPFT has appointed, I think. They add really important additional insight at board level, and it's also part of, as it were, their development process to spend some time with us. And they are Kaval Patel, who's already introduced himself. Very, very pleased to have you at your first board meeting, and Vijay Luthra, welcome to you too. And my same comment with Sarah, I hope you don't get too put off by the course of today's events, but it's great to have you on board. We'll move on then to apologies for absence. Don't think I've been notified of any, and declarations of interest. I haven't been notified of any that are in addition to those that are on the public register of interests, but if anybody's got any, then they should virtually stick their hand up right now. If there aren't any, then we will move on to the minutes of the last meeting of the board, which was held on Thursday, the 30th of November 2023. And can I ask if anybody's got any comments either on points of accuracy or on matters arising from those minutes, please? I don't see any, so please may I ask that colleagues indicate whether or not they're happy for me to sign those off as a true record. Fabulous, thank you very much. We'll move on then to the schedule of actions, which has been circulated. There are, what are there, 5 actions, I think, that are still in progress. The update on each of them, I think, speaks for itself. But if anybody's got any comments on those on the schedule of actions or any of those, then please let me know. And I've just been reminded that I've skipped ahead too quickly in my eagerness to get into the agenda, and I'd forgotten that we had some questions from a member of the public. And this is a public meeting, and we invite questions in advance. We have some questions. Karen, I'll hand over to you, if I may, to read those questions out, and then I think Mark Platts, Director of Finance, is going to respond to them. I'm very sorry for not picking that up sooner. It's one of the bad habits that one gets into chairing meetings like this. You get into a rhythm of how you do things, and these questions don't come up very often, so I'd completely forgotten. Karen.
Thanks, Kevin. I'm Karen Scott, Head of Corporate Governance, and I'm going to read directly out Mr. Bell's questions to the board. Why do LPFT staff not have online access to images taken in the X-ray scanning department at Grantham Hospital? Why does United Lincolnshire Hospitals Trust charge LPFT excuse me, if a doctor at LPFT requests that a patient has a scan undertaken at a ULHT hospital? What possible benefit to patient care does this criss-crossing charging produce? and how can waste like this be eliminated from the NHS? I would like to know what action, since the formation of the ICB and the integrated care system 2 years ago, has been taken to enable cooperation between the trusts and access to each other's systems in the interests of patient care. And finally, what are the remaining technical or organisational barriers to enablement, and what are LPFT doing to remove those barriers? And I'll hand over to Mark Platts now. Thank you.
Thanks, Karen. Mark.
Excellent. Thanks for those, Karen, and thanks for the questions as well. So good morning, everyone. I'm Mark Platts. I'm Director of Finance, Digital and Estates. So I'd like to pick up these questions. In terms of question 1, which was linked to not having access to X-ray equipment, all staff do, and they can have access as part of their role. All of the information is shared on a Lincolnshire-wide system care portal, which shows all diagnostic results, which includes X-rays, appointment information, discharge letters, medication, any particular allergies, and it stores information from all of the organisations that operate within the NHS in Lincolnshire, whether that be ourselves, United Lincolnshire Hospitals, or primary care and general practitioners. So that access is there. If it's okay, I'd like to group questions 2 and 3 because there was a theme about trusts working together and cross-charging. So this is an important one. If I take it beyond the charging for now, I think that, you know, to make sure the NHS gets the best use of resources, it's important that we don't duplicate on resources. So we don't have 2 lots of scanners, 2 lots of independent assessments within each organisation. But actually, some organisations can specialise in that. And that really helps us to kind of manage our costs globally. So rather than sort of LPFT having our own scanners and our own equipment across all of areas, then we do make use of United Lincolnshire Hospitals Trust. But it's important that we pay for that because it is a service that they are running on our behalf. So I do just want to sort of cross-reference the cross-charging bit. So to try and simplify that process, we do have block contracts. So we do not charge per scanning. It's one payment per quarter across the organisations based on volume. So just for some reassurance there, we're not paying as we go in terms of that scanning. And the final 2 questions, if it's okay, I'd just kind of link those as well because they're linked around cooperation and accessing other trust data. So since the ICB has been formed, in fact, before the ICB was formed, the development of the care portal has been front and centre to Lincolnshire. In fact, at one point we were the system with the greatest number of users across there. So the care portal is live. All trusts can have access to it. I think one of the big things that we need to do as an organisation and all organisations in our system is to help support our clinicians to understand that and improve our sort of training to make sure that access is more widely used. It is used by those that do have access to it, and it's appreciated, and the detail within the system is really helping us to improve decisions around clinical care. We need to support temporary staffing that we have in the organisation, whether it be locums or agency staff, to make sure that we can get them trained up to the levels that we have in terms of substantive staff. So just to respond to some of those, the challenges around what we have in place, we do have systems in place. I'm keen to look at how we can energise and refresh training so that clinicians have greater use of it. So I hope those answers the questions. Any other questions, please let me know and we can pick them up in future board meetings. Thanks, Kevin.
Thank you very much, Mark. I'm sorry not to have brought you in right at the beginning, which is what I should have done. Let's move on then, and I think I'd got to item 1.5 on the agenda, which is highlight an exception report from the Council of Governors meeting on the 25th of January. That I'll take as read. The 4 important decisions taken at the Council of Governors meeting then were the appointment of Sarah Whiteman as non-executive director, the reappointment of Di Bailey, and the reappointment of Tim Harry as non-executive directors from the 1st of May this year for a further term of 3 years. And for some ungodly reason, they also decided to reappoint me as chair of LPFT, also from the 1st of May for a second term of 3 years. Happy to take any questions or comments on that. If there are none, then the next item on the agenda is remarks from the chair. I don't have any that wouldn't duplicate anything that Sarah, the Chief Executive, will say in her report coming up in a moment. I may reserve the right to add a couple of things to Sarah's comments, but I don't have any comments of my own that deserve to be taken on their own. So with that, I will move on then to item 2.1, which is Chief Executive's report. Sarah.
Thank you, Chair. Morning, everybody. I'm Sarah Connery, Chief Executive here at Lincolnshire Partnership. So this is my usual board report, providing a high-level overview of key national, local issues that may impact on trust strategy, annual plans and priority setting. So first of all, want to start off with, I will assume the paper's read, but I'll just highlight a few areas to sort of bring to people's attention. I'm happy to take comments and questions on anything in the report. Want to start with a big thank you. We've, as of midnight last night, just come out of our 10th Junior Doctor Industrial Action. So I want to say a big thank you to all of the teams who've supported to keep services going, particularly our medical HR team and our medical division staff as well for pulling together to make sure that we can keep services going. As with all cases of industrial action, we'll do a lessons learnt for, unfortunately, what may be future instances of industrial action. As of writing the report, we still are awaiting planning guidance, and Mark may wish to come on to this in a bit more detail later on. But we are working together as a system continually, as you would expect us to do, to make sure that we are as ready as we possibly can be for 24-25, despite some of the gaps in our knowledge in terms of what is confirmed. But just to clarify, from the information that we have received, the mental health investment standard is protected in 24-25. I just wanted to point out through the report as well some quite difficult reports to read, so I've included there around the National Report on Learning Disability Mortality Review, and we've got our own Learning from Deaths report later on in the agenda. Some improvements have been made, but would urge people to just sort of pick up the key points in that summary report. I've included the easy read version there in the actual public report itself. The theme of health inequality still remains despite those slight improvements, and something that we're talking about as a MHDLDA alliance in the system around improving healthy life expectancy for those people who have got a learning disability is definitely one of our outcomes to be achieved. I also just want to point out we have had the independent review, you can see on page 5, from Greater Manchester Mental Health NHS Foundation Trust. We've previously discussed the BBC Panorama programme and subsequent learning from that. I've listed the key themes there in the report, which we're doing from the conversations that we've had at the executive team. We will want to pick this up through our quality committee reporting, and I know Sharon's already shared some initial thoughts with Di and Sarah for reporting through the quality committee, but this is a report for all of us. I just want to be really clear on that, and the executive team have committed, even though it will come through the quality committee strand, that there is learning in there for all areas of the trust. But as I say, I have included there the key themes which read across in terms of our trust strategy refresh. Just to add as well, people may be aware from the media that the Secretary of State has requested a Section 48 review of Nottinghamshire Healthcare NHS Trust in terms of mental health services there. We're keeping really close to our neighbours. Obviously, Notts Healthcare is one of our partners in the East Midlands Mental Health and Learning Disability Alliance, and we continue to meet fortnightly where we're sharing learning as a result of that process as well. So I'll stop there, Kevin, because there's quite a bit in the report, but I've followed the format of sort of our key strategic pillars in terms of bringing certain areas to colleagues' attention. So happy to take any comments or questions. Thank you.
Thank you, Sarah. There is a lot in there, but that reflects the fact that, as it were, there's a lot going on. I just to add a couple of comments, if you don't mind. I mean, the first is on the independent review relating to Edenfield, and like you, I read the report with real interest, and I think the bit of reassurance I took from it was that there was nothing in there that we hadn't considered as part of LPFT's response to those sorts of issues, and it kind of confirms that we were looking at the right things. And in addition to the bullet points that you've listed on in your paper, the report also flags the importance of active, visible leadership, which was one of the I think important dimensions that we reflected on as a board when we first considered this in the light of the Panorama documentary. Yeah. So that's important. So I'll invite other people in as well. Tim, you have a question.
Yeah, thanks, Chair. So Tim Harry, Non-Executive Director, and Sarah, as ever, thanks very much for a very rich and informative report. As Kevin said, there's a lot in there. I was going to touch on Edenfield, as obviously that's a really important piece that's come out in that, and the links across to our well-led review and leadership and culture. So it's obviously something that we really need to keep a focus on. The question I had got was in another area completely differently, actually, but you mentioned about estate and infrastructure and a long-term strategy development sort of across the system, which is obviously very welcome to hear, and I'm sure there are going to be some real opportunities in there. I'm just going to put my well-being champion hat on and ask and request that I assume that health and well-being facilities will be in the scope of consideration, because again, that's something that has come out from some of the site visits where those sort of facilities aren't available at this moment in time.
Yeah, absolutely. And I don't know whether people have had a chance to read the Times Health Commission as well. I was in two minds whether to put that in, but I thought I'd given you enough reading to do with the current report. But there is a theme there around I think some basics that we need to get right for our staff in terms of, as well as our patients, and I welcome people's views from the come dine with me experience about access to hot drinks, sufficient nutritious food as well when you work in really long shifts. So absolutely, and there's a role here for our charitable funds as well, in terms of making sure that we've got the ability for staff to be able to access those funds to improve their working conditions. I didn't know if Mark wanted to come in around the estates and how that will play through sustainability going forward.
Yeah, Mark,
if that's okay. Yeah, thanks, Chair. So thanks, Tim. It's a great question. We are starting to look at our estate through a different lens moving forward, certainly as we start to share our estate with wider system partners and utilising all of our estate more. But I think more importantly, what we are starting to redefine is our building utilisation processes and policies, because what we have found is as our teams are growing and the investment in mental health is continuing to increase, we are overstretching some of our buildings. And I think it's important to acknowledge that. So we will be looking at for a slightly different lens in terms of there are caps on buildings from a health and safety and a well-being viewpoint. We need to make sure that we're maintaining those, but actually we need to make sure that the digital access is there through Wi-Fi so that clinicians have a safe base that they can go to, feel comfortable to access the internet and do notes and stuff. So that's something that we're working as a system on so that we can make the best use of the broader estate that we have, not just LPFTs. And I'm really pleased to see that conversations are moving forward around primary care and access to GP surgeries and how we can enrich and support each other from that perspective. So it's an exciting time for our state and how we're going to start to utilise it.
Brilliant. Thanks both.
Thank you, Tim. Sarah, I just wanted to comment because you've mentioned it on the Come Dine With Me experience, which has been for a number of us the opportunity to go and eat with patients and staff in some of our wards. And I do want to do two things. I think first to link that to the Edenfield sort of issue, because I think it's really important that we continue to do that sort of thing, because it's a very, very good way of informally kind of testing the culture of some of our units that might otherwise be susceptible to becoming a bit closed off. So that's really important. But the other thing I think from that for us to reflect on is the inconsistency, I think, across some of those experiences that you and I have discussed, separately. And I guess that kind of links to Edenfield too, insofar as that's a measure of patient experience. And I think it showed that we've got a job of work to do around standardizing some of those experiences. Not standardizing is the wrong term, but getting a degree of equity around those kind of individual experiences in different locations, and we've got a bit of a job to do around all of that.
Absolutely, yeah.
Chris Wright.
Thank you, Kevin. Thanks, Sarah, for your report. Very helpful as usual. Mine's a comment really about the planning guidance. So I've been a NED now this is my second year. I'm into my third year of planning, and this is the third year since I've been involved that the guidance is always very late in being issued. And so the comment is, for an organisation which is trying to run its resources efficiently and effectively, how complicated the lack of the timing, how difficult it makes it for us in always having to play catch up when the guidance is so late. And I think it's incumbent upon us just to push back a little bit on NHS England and say, if we don't provide things on time, there are consequences. And so I feel very frustrated that here we are again having to operate in an environment where we're having to second guess what might happen in the future. Anyway, it's just a frustration.
Sorry, having some technical problems and couldn't unmute myself. I think that they are perfectly reasonable frustrations. Mark, did you want to comment on Chris's point specifically?
Yeah, thanks, Chris. Morning, everyone. Mark Platt, Director of Finance, Digital and Estates again. It's a great question. It's a great point. And I do think over recent years, it's getting more and more challenging because obviously at a national level, we're still negotiating the funding for the NHS to come down. I think for me, the important thing to note is that we have not waited for the guidance, and we will never wait for the guidance to do our business planning as an organisation. So only this morning, in fact, unfortunately, clashes with board today. We have a joint mental health prioritisation review process looking at all of the potential investment areas for mental health, dementia, learning disabilities and autism for the next 12 to 18 months and beyond. They're going through a prioritisation list so that we know we will have the most important cases ready to go when we receive the guidance with the actual financial values of investment coming through. So it's a really important point that we will never wait for the guidance to do the right thing and move forward with our business cases and developments. Thank you.
Thanks, Mark. That's a really important point, and I appreciate that. Sharon.
Thank you, Chair. Sharon Harvey, Director of Nursing and Quality. I just wanted to make a comment back on the Come Dine With Me approach that we've taken as an organisation briefly. As Sarah said, we're reviewing our Learning Against the Eden Field report, but I just wanted to assure the board that as part of that, we're reviewing our whole approach to quality visits as an organisation, and included in that, we're reviewing our other visits like our non-exec director and exec director visits in light of Edenfield, but also in light of the feedback and learning that we've seen through Come Dine With Me about how we've had a different approach to those visits through this. And additionally, just to let the board know, I attended the Every Voice group this week, which is our patient experience group for our inpatient service users, and they're working really hard together on a report on learning and recommendations and ideas on the back of the Come Dine With Me group work. Thank you.
Thank you, Sharon. I think that's really important. And I apologise to colleagues. I'm having some technical trouble, so there's a bit of a delay in me occasionally unmuting myself. So I apologise for that. It disturbs the flow of things, but I can't help it at the moment. Ian.
Yeah, morning. Thanks, Chair. Yeah, Ian Orrell, non-exec director. Yeah, thanks for the report, Sarah. Really helpful report. I just wanted to pick up, if I may, on the CQC inspection of Lincolnshire Secure Unit, and wondered if you could just say a little bit more about that. What was going through my mind was that sort of result what we were expecting, and can you give a bit more assurance in terms of our move to improve things?
Yeah, thank you, Ian. It was obviously disappointing to have a good to requires improvement, but if I am being completely honest, no, it's not surprising. It is a very specialist service, and one that we have struggled to recruit to, particularly post-COVID. So the particular sort of areas of learning for us, as well as the workforce, is around medications. It's one of the reasons why I was happy that we've got a sort of focused board story around that really important area, because it is quite complicated. It's sort of working in partnership with the local authority, with local primary care surgery as well, who support that contract. So I think there's a piece of work for us to do to clarify roles and responsibilities around medication for those service users, and our chief pharmacist is all over it. So recruitment a bit trickier. We need to make sure that we've got those specialist roles filled, but also around processes and roles and responsibilities. I don't know if Girish maybe wants to come in. I see he's put a comment in the chat.
Yeah, Girish, if you any additional observations on that, that would be helpful.
Yeah, thank you, Sarah. I'm Dr. Girish Kunagiri, the Medical Director for LPFT. I think with regard to the medication bit in, medications are not actually provided by LPFT. So it is subcontracted to the local GP surgery who provides. But when the report came, our name has been aligned to the medication. So that is why the report looks like it is us. So we were made aware of when the draft came, and I have asked the head of pharmacy and also others to make sure to go back to the Ofsted to get this sorted from our end. But having said that, we are also trying to make these contracts very clear and explicit in terms of who is responsible for what part of the activities. Particularly we have identified that some of the prescriptions or dispensing of the medications don't have clear SOPs and audits, which we would expect as an organization. So we have raised some of our concerns with regard to prescribing and dispensing of the medications, but it is ultimately the responsibility of the GP surgery who provides that service for them. Hope this helps. Thank you.
Thank you.
Thanks, Ian. Di.
Thanks, Kevin. Di Bailey, Non-Exec Director. Sarah, can I just follow up based on this particular issue? Because it strikes me that notwithstanding the kind of contracting issues that we need to sort, this is the real example of system working, and as a partnership between ourselves, primary care and the local authority, how we ensure that we do the best for some of our most vulnerable young people in Lincolnshire. And as a non-exec, I suppose I'd just be really interested to understand how that systemic governance around this gets picked up. So if we do our bit and primary care does their bit, and hopefully the local authority are doing their bit to kind of improve things, where does that holistic look come in response to the CQC and Ofsted report?
Thank you. That's an excellent question. I think that's something for us to put a bit more mind to, because we'll pick up our specific actions as we'd be expecting LCC to as part of that review. I'm not sure, and I look to Chris or Sharon and Girish if there is any conversations going on around what the system governance looks like in terms of the whole unit as opposed to our individual action plans, which I know will come through quality committee oversight group. But I think that might be one for us to note in our action plan, and then come back in terms of whether it's robust enough, I think, moving forward.
Chris, is there something you wanted to add to that?
Yeah, I'm happy to add. Yeah, Chris Higgins, Director of Operations. So I think we just need to double check on the oversight of the whole governance, where that's sitting. I think that's the right question to ask, Di. Just in terms of relationships in the unit, it's really positive. And I think this CQC element relates to LPFT's specific role to play in healthcare rather than as a reflection of the whole unit. So it is about our contribution to the unit. And as Sarah said, much of that is driven by our difficult staffing position that the boards were aware of and is picked up later in other reports. But yes, but we'll double check just in terms of how that is all pulled together and make sure that's clear for everybody.
Thank you.
Thank you, Di. Sorry, I'm still having technical trouble. Apologies. Kaval.
Thank you, Chair. I'm Dr. Kaval Patel. I'm one of the Associate Non-Exec Directors. Thank you very much, Sarah, for the report. And the comment I really wanted to make was just to take up after what Di's just said about system governance. The system is moving towards that community sort of partnership sort of working. And so it takes even more precedence and priority to sort of have a think about how that's going to look and roles and responsibilities of stakeholders. So I just wanted to bring that, to highlight that it is quite an important area. Thanks.
Thanks, Cavill. Yeah, I think that's absolutely right. Just to bring this item to a conclusion, only four, you'll be pleased to note, Sarah, comments. The first two are the easy ones, and that is thank you to you for a really comprehensive report, and thank you to your exec colleagues for managing through what continues to be a particularly busy period. I think I've probably said that at every board meeting for the last 3 years, which gives some insight into kind of stamina and perseverance that you and your exec colleagues are showing on behalf of the trust. So a sincere thank you for that. The third is I think to I recognise Chris Wright's concern about the lateness of planning guidance, but I think that one thing I'd be really keen to say is that the board, I think, can be assured about the robustness of our internal processes. So, however frustrating it might be to wait for kind of word from on high, I think as a board we can take confidence in Mark and the other members of the exec team to get our internal processes right. So we are not entirely beholden to whatever it is that NHS England chooses to tell us to do. And the last point is we've touched a number of times on the importance of visible leadership in kind of setting the tone across the organisation. The board is a really important part of that process in terms of setting overall tone and being clear about what our behavioural expectations are and kind of setting the tone of that culture. So on that point, really pleased, Sharon, to hear that we're doing a piece of work to make sure that we get the best out of the various types of visit and, you know, kind of engagement with services that we have. I think the timing of that is absolutely right, and really look forward to, you know, seeing the product of that, because I think that's a key part in a key element of the board discharging that really important leadership role. Let's move on then. Thank you very much, Sarah.
Thank you, colleagues. Thank you.
And we'll move on then, if we may, to item 2.2, which is the Board Assurance Framework and Risk Register. Jenna.
Yeah, good morning, everyone. I'm Jenna Davis, the Director of Corporate Governance at LPFT. Just a couple of things on the BAF and the risk register this month. So just to note that owing to the changes of the governance calendar, which we will come to at 6.2 on our agenda, it hasn't been possible for the BAF to go through the committees in months, but it has been through our performance committee with all the other committee chairs and 2 audit committee. And in line with the request of the board last meeting, we have included the full comprehensive corporate risk register. So I know it's a lot of detail, but it is there for the board. And just to note, on the summary sheet of the BAF, the numbers don't align, unfortunately, to the rest of the numbering. So I will update those moving forward. And as this time of year, we are looking at our internal audit programme to ensure that we are seeking assurance where we've got gaps in our risks. And so I just wanted to quickly bring in Sharon, who wanted to describe some of the things we're doing aligned to our quality and patient experience BAF risks.
Thank you, Jenna. Sharon Harvey, Director of Nursing and Quality. So in relation to our work on internal audit, as Jenna said, we've asked for a specific internal audit in relation to patient safety and complaints. We've asked for those 2 internal audits to run alongside each other so we can triangulate the recommendations and make sure they join up. But because we're implementing the patient safety incident framework and our patient safety incident response plan, which is about to go through quality committee in March, it's a really good opportunity for us to see where the gaps are and to make sure that our plan is in line with what we need to be delivering and join up what we're trying to do in that, really. And if it's okay, Jenna, I'll just take the opportunity to mention us strengthening NICE as well. So we have a process in place in the organisation for measuring our NICE compliance. However, we think there's real opportunities to improve that and have much more assurance against it. So we're working with regional colleagues on opportunities to do that, and how we ensure that things like our service developments, new policies and procedures consider NICE compliance as standard. So we're trying to strengthen that. Additionally, in order to strengthen lived experience voice, you'll see in the BAF actions that we're doing a review within patient experience, but to widen that and make sure we're capturing across the organisation in line with our strategy, we're also developing an options appraisal for lived experience for the board to consider and look at how could we meaningfully ensure lived experience is part of everything we do at every point of service design, service review and service delivery. So making sure that people and their families are involved in everything we do. In the meantime, because that will take some time, we are setting up what we're trying to work through the name, and we'll work that through with our lived experience colleagues, but some kind of council of lived experience where we bring the different lived experience groups together to make sure we have a collective voice. So those groups will still stand true in their own right, but we'll make sure there's a representative from each group that comes together to report directly into Quality Committee, sat alongside Quality Oversight Group to strengthen that patient voice. In the meantime, while we work through those other actions that you've seen on the BAF. And then finally, what we've agreed with the Every Voice group, which, as I said earlier, is one of our patient lived experience groups of our most vulnerable patients, people that are in our inpatient services. We've widened the scope of that group out to include our older adult inpatient services, and we've ensured that there's executive membership as standard, so that that group each time gets an update from the executive, but we hear firsthand what patients want us to hear from those inpatient wards. I hope that that's clear, but happy to take any comments, and I'll hand back over to you, Jenna. Thank you.
Thanks, Sharon. Yeah, that was very clear. Thank you. Jenna.
Nothing more from me. I'm happy to take any comments or questions on the BAF.
Thank you, Jenna. Tim.
Thanks, Chair. So Tim Harry, Non-Exec Director. Thanks, Jenna. As ever, the BAF is obviously continuing to evolve and get even better and better. I've got two questions. I think one perhaps we should take up under the People Committee in March when we look at the BAF. As a technical question around, is it possible to have full assurance on the line when we see a number of areas that the third line of assurance is a weakness, but if you've got strong first and second line, is it possible to have full assurance? So I think that's something to pick up outside the meeting. The other one I think is a more substantive one, which is so one of the gaps, and we've talked about culture and leadership already at this meeting. So I recognise what it's saying, that we have maybe got a gap around governance, but I just wondered if you could comment on how we're actually going to address that.
Yeah, absolutely. Thanks, Tim. And I think some of this will be picked up through People Committee, but obviously we are strengthening the people governance line within the organisation, bringing together a people oversight group. And I would look to Amy if Amy wants to comment in terms of how we're strengthening the voice of staff within our governance structures.
Yeah, I'm happy to come in. Firstly, we've had more active staff networks, and now we have a council of staff networks, which is chaired by our chief executive, Sarah Connery, and that council of staff networks is going to have a direct line into the People Committee with a report coming into board. Tim, I think in terms of wider around culture and leadership, we very much look to have some discussions, obviously in our board development session, and to utilise private board for some of those discussions. So thank you, and sorry, I forgot to introduce myself. I'm Amy Beaton, Director of People.
Yeah, thanks both. And it was that broader piece I was sort of interested in. So yeah, there's discussion to be had. Thank you.
Thanks, Tim. I've got Di next.
Di Bailey, Non-Exec Director. Thanks, Jenna. Just as you were talking there about the BAF, and we did give this a really good look at the first Performance Committee a couple of weeks ago. What emerged from that was particularly under a number of gaps in controls, we highlight data or limitations with data that is impacting on our intelligence around patient journeys through our services. And this is something that we wanted to ask the Sustainability Committee to pick up in terms of going forward about how we address that gap, particularly around data and data analytics. My reason for flagging this, because it is there under the Performance Committee report, but is just to indicate to board, I think, how now we've got the Performance Committee, we're starting to identify those cross-cutting issues and how we address some of those interdependencies. So I think it's one example of where the BAF is becoming more dynamic than it perhaps has hitherto. So just thanks for that.
Thanks, Di. Just one quick comment from me, Jenna, and I think that as Tim's alluded to, both the BAF and the risk register are still evolving, and I think that we're not quite there yet with all of them, partly because some of the kind of moving parts of the governance structure have changed, and I think that the BAF will take on a different kind of complexion once the performance committee gets properly into its stride, because it will, as Di's just said, give us a stronger focus on those cross-cutting issues and really bring the BAF to life a bit more. So I think that's important. I've got one more comment from colleague, then I'll let you say anything that you need to say to bring things to a conclusion, Jenna. So Ian.
Yeah, thanks, Kevin. I really just wanted to build on your very last point, really, and just say that the audit committee as well is seeing this in a similar direction, for want of a better way of explaining that. And I was pleased at the outset of this particular presentation where we brought in the example of a couple of internal audit reviews. And what I would say is that sort of an external view of things is something that we should encourage. And by external view of things, I'm not limiting things just to internal auditors. I think it's a tool that we should use to best effect at the appropriate time. So yes, just a comment from me. Thank you.
Yeah, thanks, Ian. Noted. Jenna.
Yeah, and I was going to bring in Ian, so thank you, Ian, for coming in. And I think this is around how we are strengthening audit committee to give it greater oversight of risk and risk processes. So that'll really help us build our maturity moving forward, because I think the power of the conversation this morning with Sharon and Amy coming in is actually, how do you bring the BAF to life? It isn't a process, it is there, in terms of strengthening assurances and really highlighting gaps and helping us manage risk in a better way.
Yeah, absolutely. Thank you for that, Jenna. So thank you for those comments and that discussion, which I think is helpful. If we may, let's move on then to item 3.1, which is the Guardian of Safe Working report. Girish.
Yeah, thank you, Chair. I'm Girish Kunigiri, Medical Director. So with regard to the paper, I'll take it as read. The purpose of this paper to the group is to reassure the board that our organization is compliant with the terms and conditions for the junior doctors contract, and this is independently seen by Guardian of Safe Working, who is separate from that of the usual line management structure we have. Usually we bring an annual report, but because we are still in February, so we have included nearly the last 3 quarters of the data for this. I know that there are some new members in the committee, so for the benefit of them, when it comes to the training, there are different levels of trainees in the organization. Once the doctors finish their 5 years of training in medicine from the medical school, they are generally posted to our organization or any other secondary care, where they do what is called as the foundation year 1 and 2. So usually the trainees are posted for about 4 months in different specialties, including mental health, during this 2 years training. And then once they finish, then they go into the core training, which is for 3 years, which is like the core training in adult psychiatric services or the eating disorders or so on. And then once they finish the 3 years of core training, they go into 3 years of specialist trainers. And after they finish that 3 years, then they become the consultant psychiatrist. So in addition, as an organization, we also have trainees from the primary care who are called the GP trainers, who are generally for 4 months. And when we have some gaps with any of these, then we as an organization recruit what is called as MTI trainees. They are generally from abroad, and then if there is a specific gap for few months, then we have what is called as the fixed term locum appointment in service. So what this paper says is in terms of are there any deviations in terms of the working directives for the trainees. The trainees are allocated by the deanery in the East Midlands, and the numbers vary every 4 to 6 months, and each of the trainers have different period of training within the organization. Like, for example, the foundation trainees and the GP trainees are here for 4 months. Core trainees rotate every 6 months, and senior trainees rotate every year. So that's why you see in the paper that for every quarter or every month, the number of people who are working is very different, and all the trainees are expected to be on the on-call rota, which is after 5 p.m. and before 9 a.m. and it is based on the pro rota basis. As you can see that there are some vacancies in the on-call rota, which again varies based on the number of trainees which the deanery allocates for us. But generally in our organization, it is less than 3%, and these are generally filled up by our own existing doctors, so which is a good thing, so that we get the continuity of care, and also we get the quality doctors within our organization. So this rarely means that there may be some times when the doctors are asked to work beyond their working time directives, which is more than 48 hours in a week, or sometimes having to work more than 12 hours shift, which is then reported as an exception. So in the last 3 quarters, we had about 11 out of 1,250 on-call shifts, which means it is less than 1%. So it is not a problem at all. And all these doctors who are asked to work more than what they are contracted to, they are compensated by providing them the right toil, which is time off in lieu. Just to give an example, if there is an unexpected sickness with no notice, so the doctor who was doing the on-call, say from 5 p.m. to 10 p.m., he will be asked to continue for a couple of hours until we find an adequate replacement for this. So I'm glad that our organization has never received any fine for breaking any of these exceptions. So it is reassuring that we have different measures within the organization for doctors to make sure that if they have any concerns, they are able to raise, like, for example, monthly junior doctors forum, having a bi-monthly local negotiating committee, and we have Speak Up to Guardian as well. And I myself attend the Junior Doctors Forum every month, and also conduct the Medical Directorate surgery every 2 weeks, so that I can hear directly the concerns if they have not been managed by their line manager. So in summary, our organization fulfills the junior doctors contract in line with their terms and conditions, and I'm happy to take any questions. Thank you, Chair.
Sorry, still having problems getting myself unmuted and making Teams work for me. Thank you very much, Girish, for going through that in some detail. 2 colleagues that have got comments, Di and Amy. So Di first.
Thanks, Kevin, and thanks, Girish, for that explanation. Di Bailey, one of the non-execs, and I have to confess I'm not one of the new execs. But I think if I hadn't had your explanation, Girish, I would have really struggled to make sense of what of the information that was in the paper. So I can't even offer as a mitigation that I'm new, because I probably should know this. But I think one of the reasons I struggled with the information that was in the paper is because I struggled to reconcile some of the numbers. And So, for example, you know, where we talk about vacant shifts out of hours, it wasn't clear whether those shifts were covered. And where we talk about the rota in terms of how many shifts are being covered by locums, I wasn't sure how many locums we were talking about. So it was hard to get a sense of the volume and quantity of work that some of these people are doing for us. And I absolutely get what you've given by way of explanation. And I think in the executive analysis, there is a sentence that says, you know, we've mitigated where people have done over and above what they should do by looking at their rotas to make sure we're compliant. So in the light of that, I just wonder whether we could look at how this report comes to us in future, Kevin, because I think without that explanation from Girish, I would have really struggled. And I think it is important. It is important that we're absolutely assured that we're looking after our medical workforce. So I'm happy to provide some comments outside of the meeting, but I think we could look at this and make it a bit more accessible for future.
I completely agree with that, Di, and I thanked you, Girish, for your explanation around the paper. But I'm like Di, I don't think I'd have properly been able to appreciate the contents of the document without that explanation around it. So I think there's a piece of work to be done to think about how we present this information in future. And Di, I appreciate your offer of, you know, kind of help around that, and I'm sure Girish will take you up on it, and we can get to something which may well be easier to write, as well as, you know, easier to digest. Amy, take you, and then we'll have a break before we move on to the next agenda item. So Amy.
Thank you. So Amy Beaton, Director of People. Girish, just probably building on some of what Di said. So on page 2, I think the way it's presented and reads is that we've got a vacancy, a junior doctor vacancy, because of a lack of being able to provide clinical supervision. Now that might be the case that we've got a lack of a clinical supervisor in one of our areas, but I'm quite confident we don't say no to taking a junior because of no clinical supervision, and we work around that. So probably building on Di's point around the way it's presented, it reads like that, but you and I know that you know that's not the case. And I suppose just for boards assurance in terms of clinical supervision, it is a national issue, and you know it is requiring on really very busy consultants volunteering to provide that, and Girish and I are absolutely working actually through our East Midlands Alliance around clinical supervision and how we can explore more innovative things such as virtual supervision to provide across the East Midlands, and also we've been having conversations and exploring our retired doctors returning to just provide supervision in order to mitigate some of that. So thank you.
Thanks, Amy. And just one last comment, Girish, on the format of the paper, and this is not aimed at you. I think it's aimed at anyone that's drafting papers for the board. I think this is not a plea for people to write more. It's a plea for people to be absolutely clear about what it is that they want the board to know and understand from what's being presented, and you know, be absolutely kind of ruthless around focusing on the key message. So you know, as I say, it's not a request that people write more. In fact, it may well be that you write less, but just be absolutely focused on what messages you need the board to take away from it. But thank you very much, Girish. Thank you for the report and for speaking to it and helping us to understand better at the key messages from it. Now, if colleagues are happy, we'll take a quick break to enable people to make themselves comfortable and or have a cup of coffee or whatever they want to do. It's now 22 minutes past 10 according to my clock, so we'll reconvene please at 10:30. Thank you very much. Right, welcome back everybody. Let's proceed with the agenda where we left off, which was still with you, Girish, with item 3.2, which is the Learning from Deaths report.
Thank you, Chair. Good morning, everyone. I'm Girish Kunigiri, the Medical Director. This is the paper on learning from deaths, and the purpose of this paper is to report and assure the board on our quarterly data on unexpected deaths, to make sure that any such death are adequately investigated, lessons learned, and measures are put in place to prevent such mistakes happening. Just again, for the purpose of the new board members, any deaths which happen for patients who are within our organization or who have been discharged in the last 6 months, if they are not natural or unexpected, then as an organization, we do investigations at 3 levels. One is called as the serious investigation. The second one is the internal desktop review and the enhanced mortality review. And the third one is the leader, which is learning from lives and deaths of people with learning disability and autistic people. So those deaths which are unexpected or unavoidable, or if there is an injury which results in serious consequence to the patient or the family, such as a death or an assault, will be investigated as a serious incident. Those incidents which don't fall into that category, but they are unexpected deaths, they will be reviewed under this internal desktop review or the enhanced mortality review. Now, we have a very robust process within the organization in terms of reviewing all the deaths which happen for patients who are on our books or who unfortunately died within 6 months after discharging from our organization. So they are triaged every day, and then depending on the case, if they are unnatural or unavoidable, then they are further investigated based on this one of these 3 headings. Now, some of the things I will not go into the report in general, just to give you an example with regard to the first figure or the first table, which is the deaths in adult community services. There were 9 deaths, of which further were either investigated in detail or waiting for further information to be investigated under one of these criteria. So similarly for the older adults, where we know that there will be more natural deaths, there were 199 deaths, and out of which none of them needed further investigations based on the criteria which are laid down nationally. So with regard to the leader, that is the deaths for people with learning disability and autistic conditions, we had 8 serious incidents. 11 are in the initial stage of the review, and 1 is undergoing the internal clinical review. So in terms of the general observations in our organization, the number of unexpected deaths or unavoidable deaths is usually within the normal variance, and all the reviews were done within the time frame, and thanks to the quality team to do this. We always have lessons to learn and put things to make sure that it doesn't happen again. And the appendix, which is attached, provides the summary of the good practices and the areas where we need to improve. So in terms of our own internal mechanism of learning from deaths, all these reports are discussed in detail in the Mortality Surveillance Committee, which I chair, and all the key things which are to be learned, they are discussed in what is called as organization learning meeting. And from there, it goes to all of the divisions where they are discussed and disseminated to the clinicians. In addition, we also share our findings with the ICB, and also all the clinicians receive the monthly bulletin on the learning from any of those incidents. I need to just bring to the board that with the new governance structure which is in place, we are now exploring how we can strengthen our organization learning mechanisms and how this fits with the current governance arrangement, and how we measure the impact of our learning, which has always been a challenge. So in summary, in our organization, there is a robust mechanism to identify all the unexpected or unavoidable deaths, and this is closely scrutinized on a daily basis and discussed in detail, and those which need further investigations, they are definitely done. And currently there are discussions ongoing in terms of how we make sure that the learning is widespread and evidence having a positive impact. Happy to take any questions, Chair. Thank you.
Thanks, Girish. That was a comprehensive and helpful report. What I think the board particularly wants out of this is, assurance around, not so much around the process, but around the application of the process, as it were. Assurance that we're properly taking on board the learning from individual cases, and I think the report does that. So that's helpful. Got a couple of colleagues who want to come in. Chris Wright.
Thank you, Kevin, and thanks, Girish, for the report. So you touched on this towards the end about the report that goes up to the ICB. So I'm really interested in, obviously I'm interested in the learning that we do internally, but I'm also interested in how the lessons are learnt more widely in the health economy that we operate in, and indeed beyond some of the other care systems that we participate in. So how do we go about ensuring that those lessons are taken on by GPs, by adult social care providers, and so on and so forth?
Yeah, thank you, Chris. That's a very interesting question. I may have to go back and then check how this, what is the mechanism of the system-wide learning. But what I can tell you is that our quality committee does receive all the learnings which happen at the organization level, which is then filtered across the divisions in terms of the learning. And also what happens within the region as well as nationally. We have a mechanism where we get regular information about those learnings, and we do discuss in various forums in terms of going through those learnings and how we disseminate that to all of our divisions and to the clinicians. Thank you.
Thanks, Chris. Do you want to come back, Chris, because you're muted, so I can see your lips move?
Sorry. Thank you, Girish. Sorry, Kevin. Just, yeah, I do think it's really quite important that we think beyond LPFT here about the learning, and certainly maybe Cav will have a view about some of this as well, how it feeds back into the primary care system and beyond, just so we can join up the activity on the ground and people can learn from those lessons. Yeah, thank you.
Thank you.
Thanks, Chris. Di.
Hi, Bailey, non-exec. I didn't have any queries about the data in this report, Girish. I thought it was really clear, so thank you for that. It was just a couple of comments, really. One was in relation to the governance, and I just really wanted to reinforce the importance of making sure that we still have sight of this information. And I think we've decided that I think it's the quality improvement group will do some of that heft around some of the learning for us going forward, but I think we've got an opportunity for that to play through, not only now through quality committee, but also more broadly into performance committee. So we absolutely mustn't lose that going forward. So thanks for highlighting that in the report. I just wanted to say that I was disappointed to read in the summary report that one of the areas where we still need to do some work is around the handover process with ULHT in particular. And I think this is something that Chris was alluding to in terms of that wider system working. The reason that I was disappointed when I saw that was because several serious incident reviews that have come through quality committee have highlighted that we've had issues of transferring care between ULHT or the acute sector particularly and ourselves. And I think this does go back to where is the system governance around some of these issues. I think the first place that this ought to go is to that system level quality committee for further conversations, because it's obviously not being fully resolved given what we're seeing now around learning from death. So I think there is some work to do in terms of those transitions, and absolutely I think going forward should be fed into that system level quality committee work meeting. Thank you.
Thank you, Chair. Can I just come back quickly to that, please?
Yes, you may. Yeah.
Yeah. Thank you, Di. I mean, I do agree that there are some issues with regard to interface. But having said that, there is definitely some positive relationships which have been built. I mean, just to give an example, with regard to interface in ULHT, now we have a clear agreement in terms of who will provide the support for people who are having significant behavioral problems in children when they are admitted to the pediatric ward in ULHT. So we have jointly sent a memo related to that so that clinicians are very clear. So definitely, as and when we identify what the other issues are, now we have set up that platform where we can mutually discuss as well. Thank you so much.
Thanks, Girish. I've got Ian next.
Thanks, Chair. Yeah, actually, mine was around the ICB, and Chris has effectively picked that one up, Chair. So I think you can move straight on from me.
Thanks, Ian. Covell. No, Tim. Sorry, I've got Tim next. Apologies.
No. In the interest of time, Girish and Chris and I have answered my question really, which was around governance of cross-provider incidents where there's a number of parties involved and how that's looked at. So thank you.
Okay, thanks, Tim. Covell.
Yeah, thanks. I'm Dr. Cavil Patel, Associate Ned. Girish, thank you very much. This is a really difficult area, and as a clinician, I appreciate that. Every number is a tragedy, really. So my comment really was that as a GP, unless you're directly involved in a serious incident, you're not going to be notified of the learning outcomes. And I just wanted to share that with the board. So I think Chris's point about the wider learning, there is an opportunity on how our interface addresses that, so that ULHT, primary care and other areas not only are not only talking about clinical pathways and how things can be made better, but in parallel are also talking about incidents that have happened and what the learning is out of that. So yeah, very difficult area, but I know the interface will address this.
Thank you, Covell. Got a last comment then on this item from Amy.
Thank you. So Amy Beaton, Director of People. Girish, obviously this paper comes regularly into board, rightly so, and has specific learning and improvement identified for every death. I think it's a real positive what you discussed in terms of the organisational learning forum in our governance structure. I think that's a real positive step forward, and I wonder therefore if we want to consider as potentially an annual report on this, or whether you consider how that may work, which analyses the themes right across, so that we can demonstrate that learning and improvement if we're seeing regular themes come, rather than just purely looking in on each one. So I would ask you to consider that. Thank you.
Yeah, thank you, Amy. Sorry, Chair, can I just respond?
Yes, of course.
Yeah, thank you, Amy. I think that's a very good point. I think in terms of organizational learning, it's not just with regard to the deaths, but we also look into all the other kind of incidents, complaints, DATEX, so that, if the board wants that for assurance, I can definitely work with Shannon and bring a report on an annual basis. Thank you.
Thanks, Girish. Thank you, Amy. Girish, two comments from me. The first is thank you very much for, as I said, a comprehensive, helpful document. And to Cavill's point, I don't think you particularly need actually to be a clinician to recognise that all of the numbers in this report are tragic, as it were, and I think as a board we feel that very, very strongly, which is why we look for the assurance that you provide in this report. And my second point is that the really important dimension of interface between organisations. So really pleased that we've got some work around that. You take that away and make sure that feeds properly into system work. So thank you very much for that.
Thank you, Chair.
Let's move on then to item 4.1. Amy, I assume you're leading on this.
Yes, I will start us off, Kevin. Obviously, there's 3 domains within the equality delivery system, and Girish is executive SRO on domain 1. So I will be handing over to Girish once I've covered domain 2 and 3. The equality delivery system, and I'll refer to it as EDS going forward, it is a requirement within our NHS standard contract that we upload onto our website our findings in respect of the 3 domains outlined in the report and the resulting action plans to improve any findings where appropriate. So therefore the board are asked today to approve the publication of the findings and the plans that are included in the appendices. So 3 points really from me in terms of my area. So EDS is an improvement tool, and I would say it's been helpful to complement our plans already in existence. However, what I would certainly say from domain 2 and 3 perspective is we've already done a lot of work in this space to understand the inequalities that exist in terms of domain 2, and have had discussions around how we can address them, including 2 recent board development sessions. And indeed our refreshed strategy articulates our ambition in this space. So whilst the tool has been really helpful and it does slice the data differently, which has provided some more insight, I would say its focus is more narrow than the focus that we have set ourselves as a board. So therefore, a lot of the findings were not a surprise. They were already known, and our action plans already in existence for our ambition were relevant for this EDS submission. So, for example, as a board, we are really familiar, really understand our work around what we term belonging, which encompasses the bullying, harassment and violence and aggression work for both staff and patients. And you'll see in the report our action plans around that are relevant for domain 2 and sit in the appendices. So We recognise the work we have to do in this space from our data and engagement with staff and how it disproportionately impacts on some of staff with protected characteristics. But all the plans have robust governance and accountability, and as it spans multiple director portfolios, it shows we're tackling some complex and sensitive areas. I think it's also important to note the scoring was discussed, so it's been through our oversight group, it's been through people committee, and due to the criteria we could have argued for and against why we would score ourselves at the maximum grade 3, but also at grade 2 for some of the domain subsections within domain 2 and 3. So whilst the paper does articulate some really positive findings, such as the work we've done around our representation at board and the health and wellbeing findings showing that some we can see some over-representation for some of the staff with protected characteristics when compared to the workforce averages. We've concluded that we do have improvement to make, and I think what was more important to us as an organisation is acknowledging the work we have to do and focusing our efforts there rather than spending more time gathering evidence to justify a scoring. So across domain 2 and 3 we've graded at a level 2. In all of those domains and subdomains, which means we're achieving in terms of our scoring criteria, and we've got movement to become excelling. And then finally, for me, I think what's worth saying, as a board, we will recognise in the equality, diversity and inclusion space in terms of staff, we have the EDS, we now have 6 high impact actions, we have the workforce race equality standard, the workforce disability equality standard and the gender pay gap. And I think it has been heard and recognised by NHS England that we have a lot of assurance and reporting to do, and they are looking at a one dashboard. But for us as an organisation, we will stay focused on delivering our ambitions, and I'm confident by doing so we will be able to provide the level of assurance being sought through those multiple routes anyway. That's
Thank you, Amy. I mean, I think that it's right to say, isn't it? Forgive me, I didn't mean to cut across you then, apologies. I've got a bit of a lag, just to add to my muting and unmuting woes. I've got a bit of lag as well. It's correct to say, isn't it, that this has had a thorough going over in people committee too, as have the individual scores. So this comes to board with a level of assurance provided by people committee anyway.
Absolutely. And I'll hand over to Garish.
Thank you.
Yeah, thank you, Amy, and thank you, Chair. I'll keep it very brief. As Amy was discussing about the staff, there is a requirement for us to ensure that we do everything to manage the health inequality among our patients in Lincolnshire. And as a starter for 10, and as per the standards, we had looked at 4 different domains in 3 different services. So one was talking therapy services, which is based in primary care. The second one is mental health support team, which is a school mental health team in CYP, or children and young people. And then is the mental health liaison services in Boston. So what was definitely positive is that the recovery rates and patient experience in the BME community was equivalent to that of the general population in talking therapies, which is 50%, which is really good. And also in the school mental health team, we have been phenomenal in supporting the children, which is again positive. And again, as Amy said, we have rated 2 on most of the items. But what is key for the board to be aware is that we have many more areas where we need to collectively tackle the challenge on health inequality. And the 2 key things for me is, one is in terms of the data collection, particularly with regard to protective characteristics, and having such data to collectively analyze and reshape the service provision based on these measured objectives involving the service users and carers in such decision making. So in terms of moving forward, I'm glad that we have the new strategy where we have focused on population health pillar, and the board is committed, and we have launched the PCRAF, which is the framework to tackle with race health inequalities. And we have the exec lead, which is myself, and we are in the process of recruiting a health inequality lead in the organizations. And all the teams who have done this work so far have a clear action plans involving the stakeholders. So in summary, I know that as an organization, we need to do a lot in terms of managing this health inequality in Lincolnshire, but I think we are in that journey. Thank you.
Thank you, Girish. And sort of in a bit of an echo back to the previous discussion we had, the issue of population health inequalities is a system issue, not just an LPFT issue. So it's really important that we engage with and support the kind of cross-system work in the ICB around health inequalities, and particularly take a health inequalities perspective into the system conversations that we have around allocation of resources and so on.
Yeah, thank you, Chair. Just to assure on that point that our Chief Exec chairs the Mental Health, Dementia, Learning Disability Alliance for the organization, and we have a subcommittee under that umbrella which specifically looks at health inequality across the system in mental health, which I'm actively part of it. Thank you.
Yeah, thank you for adding that, Girish. It's helpful. I don't see any questions or comments from colleagues. They were both really helpful in and comprehensive overviews of where we are that provide a good level of assurance. So thank you very much, Amy, and thank you, Girish. We'll move on then, if we may, to item 5.1, which is the Integrated Performance Report. Mark.
Morning, thanks, Chair. So good morning, everyone again. Mark Platts, Director of Finance, Digital and Estates. Given the revised governance structure that we've referenced quite a couple of times in the meeting, this Integrated Performance Report has been reviewed at a number of different levels across the organisation now. So both at an operational divisional level and at a trust-wide delivery oversight group and a trust-wide performance committee. So I'm going to present the report to board today on that basis that it has been scrutinised through a number of different areas, and just pick up on a couple of key highlights if that's okay. From an operational update viewpoint, I think it's important to note the positive work around waiting times that's happening across a number of different areas, but the one noted in the report is children and young people. However, it's important that we focus on all of our services and keep that good work going. And I know Chris Higgins, our Director of Ops, will be picking up on that as we go on later on. From a quality viewpoint, the report demonstrates the ongoing work to drive a reduction in incidents and the need for restraint, whilst also actually proactively supporting the ongoing focus on giving patients our voice. Patient Voice Guardian has been a really successful role that's coming, even though it's relatively new in its development. From a people perspective, continued innovative approaches to recruitment is really starting to help stabilise and grow our teams as we go through, and I think we're starting to see that now in the metrics in terms of reduced turnover and other areas around sickness as teams start to stabilise as well. So obviously a lot still to do, but really positive growth on that one, and movement from the people team and our recruiting team. So from a finance viewpoint, I keep it really short and sweet. We are continuing to meet our current year-to-date targets, and we are currently forecasting to meet our latest financial plan that was approved recently by board. So I'll leave it there, Chair, if that's okay, but welcome any questions on it, given the number of reviews it's gone through.
Yeah, thank you, Mark. I was about to say that this has had several coats of looking at in various different forums, and I think the important thing for the future is that as the performance committee beds in, as it were, to the governance structure, I think as a board we want to look forward to performance being reported in a different way, in a way that demonstrates, as it were, the value that the performance committee is adding. So I think what I'm looking for is a much slimmed down IPR, that because the whole of the suite of the performance data has been through subcommittees and the performance committee, and so what we get as a board is almost an exception report that just highlights the things that performance committee is either concerned about or is unable to resolve. And I think that moves us away from reporting information and focuses us much better on providing insight. Comments, Chris Wright.
Thanks, Kevin, and thanks, Mark. I just wanted to make a very brief comment about where we are as a trust based on what this information in this report is telling us. And we're operating in an incredibly complex and difficult macro environment. But I think we should take and pay our colleagues a lot of credit for the work that takes place every day, the progress that's being made. If you look at us from a sustainability lens, you know, there's lots of reasons for this, but our financial performance is very solid. If you look at our people strategy, it's coming to fruition and we're making some really good progress. And if you look at things operationally, of course, we've got pockets where we need to improve performance, but generally this is a very positive picture. And very rarely do we celebrate the positivities, because we're always looking for things that are not working quite so well. So I'd just like to just recognise the hard work of our colleagues and teams across the trust. Thank you.
Thank you, Chris, and that's a really important point, and thank you for making it. It saved me doing it. Tim.
So thanks, Kevin. Tim Harry, non-exec director. One very quick comment and a piece of assurance for the board. Obviously, the situation regarding recruitment and vacancies has changed substantially over, sort of recent times. So the focus of the People Committee is as much around sort of those hotspots, and one of those is one of those cross-cutting pieces around medical agency spend, which is one of the things that's sort of highlighted in the finance report. So I've asked Geerich and Amy if we can have an item on that at the next People Committee and dig into that a little bit.
Thanks, Tim. That's helpful. I wonder whether it would be helpful, because I think perhaps we ought to reorder in future at the papers. It would be helpful, Di, if you wanted to add anything from the perspective of item 5.3 on the agenda, which is the report from the Performance Committee, which I think probably should have come before the IPR, because it frames that, the IPR report. So if I skip ahead an item on the agenda and ask if there's anything that you particularly want to comment on from that perspective, Di.
Thanks, Kevin. And absolutely, one of the things that we focused on at Performance Committee is how we can add value and how we get that more strategic vision in terms of the IPR. So we're on it. We've got some work to do around changing the structure of the IPR, which will help with that coming forward. And we've also, at the Performance Committee, we also talked about how to help the Performance Delivery Oversight Group do some of that more operational analysis so that we absolutely remain strategic. I'll say no more about that because it's in the notes from the Performance Committee, and I hope they were fairly self-explanatory. As a result, the main thing that came out of it was around our risk in relation to, at the moment, we currently, as Mark says, we look at information to do with waiting times, but we do it primarily on a service level. And what we need to shift towards is really understanding the impact of those waiting times on the sort of access experience when people are in our services and the outcomes for them. And so we've actually asked for the board to support the recommendation that we add that more holistic risk around better understanding patient flow, which will support the way that the performance committee gets behind some of the data going forward. So that's really all I need to say, I think, at this point.
Thanks, Di. That's really helpful and exactly what I was hoping you would say. So I'm grateful. Thank you. Mark, thank you very much for the report. I think having the performance committee to add some context to it and provide that additional layer of assurance is really helpful, and glad to see that starting to take shape. So we'll move on then to Chris. You've got both the Director of Operations report and a position statement on the Psychiatric Intensive Care Unit. It might just be helpful for you to introduce them both together, as it were, and we'll take discussion on both of them at the same time.
No problem at all. Yeah, so Chris Higgins, Director of Ops. So just very briefly, in terms of things that have been flagged already, but worth just pointing out, is recruitment retention is much better across the board. Still got some hot spots, and what I would say, as I said in the paper, it's no less felt, the pressure is no less felt in those teams that are still under pressure, but on the whole it's an improved position. You'll see Lincolnshire Secure Units, one of those areas, as referenced earlier, that's challenged by its staffing position at the moment, but hopefully we're seeing some green shoots of improvement there. The other thing to flag, because I think there's a lot of work to be proud of there for the teams in terms of waiting times, you'll see that the position on autistic diagnosis and CAMS is much improved. Still a long way to go, but we're in a good position and making positive progress. So really pleased with that. And just one small thing just to say on that, we've got a couple of people that are waiting over 52 weeks, which is obviously something we don't want, but just say they're not people that are out without service. They've been supported by specialist services. It's just the type of treatment they need is something they're waiting for. So they are being supported. It's just there's a specific specialist treatment they need that they're having to wait for, hence we're classing that as a wait. So just thought it'd be important to make that point. The other thing just I wanted to say is around cost improvement. Just to say there's been a real positive approach to that from across the organisation, across the operational services. People have embraced it in the spirit that we hoped, and a real rigour and discipline around financial management you'll see coming through in future reports, and hopefully developing a really robust and deliverable SIP programme. So just wanted to mention that. I'll pause if you want before I go on to the PQ. There's any questions, but otherwise I will press on. So board members be aware that the Psychiatric Intensive Care Unit, our male Psychiatric Intensive Care Unit, was temporarily closed back in November 22. As a matter of accuracy on the paper that I've presented, is the decision we took was actually in October 22, just the unit didn't close until November. I won't rehearse the background. You know the story here. It's been temporarily closed. We've been recruiting staff to get us into a position to be able to open. That has been successful. We've got a fully recruited staff team, so operationally we're ready to go. Unfortunately, Legionella was discovered on the unit at high levels, considered to be unsafe, and as you'll see in there, the recommendation from our health and safety colleagues and water safety experts is that it's not safe to reopen the unit at this stage. A process of flushing and testing to get the unit clear has been undertaken since the Legionella was identified, and as yet we still don't have the readings that we need in order to reopen. Now, after an urgent meeting last month, it was felt that there was better grip and understanding of the issues and better controls and plans in place to be able to eradicate the Legionella to safe levels. There is a test due back this week that will determine what happens next. If that's clear, touch some wood, we'll be on the home straight, and the plan that's laid out in here that says what we should be open in April should come to fruition. Well, safe in April to access and opening in May. If it's not a good result, then we'll be having to look at a different plan, and maybe we need to look at some options. Obviously, this has gone much longer than we'd all intended and hoped for. So nevertheless, whatever happens next, there'll be a lessons learned process, because I'm sure over the course of the period of temporary closure, there'll be things that we can learn and do differently in future. But The final thing I'd say is it's been a real team effort. We've got different executive leads from estates, health and safety, operations, quality, all working together on this to make sure that we're doing the right thing we can for patients, whilst balancing the risk that's posed by the Legionella water. So I'll pause there, but happy to take any questions.
Thanks very much, Chris. And I was encouraging you to move on, but I couldn't get myself unmuted quickly enough to speak. So apologies for that. A couple of quick observations on the PQ first, and that is one really pedantic point. The paper says April 2023, and I think that was probably nearly a year ago, rather than April 2024.
My mistake.
But I think that's a flippant point. I think the important point from a board perspective is to be assured that we're doing everything we reasonably can to eliminate the problem that we've got, and the actions that you've described, I think, provide that assurance. You know, we're not sitting around waiting for things to happen, so that's important. My second point is on your first paper, your operations report, Chris, and it's about recruitment and retention. It's not specifically about your paper, but I just wanted to use it as an opportunity to mention the fact that we had a really excellent recruitment day in Boston at Boston United football ground on Saturday. I was really pleased to drop into, and it was just fantastic to see the number of people that we had turning up, interested in working for the trust, and really great to see representatives of teams and a couple of members of the board, Mark and Amy, there facilitating, you know, that day. It was really, really good to see, and absolutely, you know, a credit to everybody involved. So thank you for that. Tim.
Yeah, thanks very much. Two very quick comments. One, I think probably need to recognise that as frustrating as the delay is, having got the staff and redeploying them, that's a training opportunity, etc., isn't it? So there is a plus side around that. The other thing is around a question around the water expertise, and I don't know if it's UKHSA who are doing the testing, but are they also providing some water expert system advice? Because they can be very good, and these things can be tricky. I do appreciate that.
If I may, I'll invite Jenna in, who's our health and safety leader in the exec team, if that's okay.
Yeah, thanks, Tim. So we are using an external company to do the water testing, and we do have an external water safety expert that is providing advice and support, both from a health and safety perspective, but is also supporting Mark from an estates perspective about what actions we need to take to ensure that we eradicate or make it as safe as possible for patients.
Thanks, Jenna. Thank you, Tim. Don't see any other questions or comments, Chris, so thank you very much for both of those reports.
If I may, Kevin, just before I finish up, just to point out, hopefully it goes without saying, but at the heart of all this is we've got patients that are placed out of area, and that's not good enough. And, you know, I just want to say that we are working as hard as we can to get the unit open as quickly as possible, but it's got to be safe. But I just want to acknowledge that it's about people at the end of the day, and that's why we're working so hard to get it as open as soon as possible.
Thank you, and that's what lay behind my comment about board assurance, Chris. You know, this isn't, as you say, this is not an academic exercise. This is because we've got people out of area and we need them bringing back, and the board looks for assurance that we're doing everything that we can to get those people back in Lincolnshire as quickly as we can. So I appreciate that. Thank you. We'll move on then, if we may, to report from the audit committee. Ian.
Yeah, thanks, Chair. Ian Orrell, Chair of the Audit Committee. I think you'll find it's just a short paper. I assume it's been read. Gives recent history in terms of what we've been looking at over the range of governance issues. Just a couple of points I'd probably want to bring out. First of all, board will know that our work with internal audit has had one or two issues in terms of introduction of the new audit team, but there are signs of improvements there, so that's pleasing to note. But I'm conscious that there is more to be done there, and we'll be keeping a close eye on that. And then just a couple of things in terms of the future. Won't repeat all this, but the BAF and the risk management stuff that we were talking about earlier on the agenda is very much in our sights. And just to end on a positive note, the external auditor, I think it's fair to say, is very relaxed about our position moving into the year end and the range of issues that need to be undertaken at that time. Yeah, fairly stable position from the audit committee, but happy to take any questions.
Thanks very much, Ian. I'm grateful. I don't see any questions or comments, so with a single bound, you're free. And we'll take the final substantive paper then, which is 6.2, the review of committee membership and the meeting timetable. And I hope, Jenna, that you're going to speak to this.
Yeah, so I'll be brief. So as part of the review of our governance processes that commenced on the back of a well-led self-assessment, the process is now concluding, and we are recommending the attached membership for the board and its committees. You will note from the paper that we aren't making substantial changes at committee level, therefore we're just asking that the existing terms of reference be in effect rolled over until we go through the governance processes to get the new ones approved.
Thanks, Jenna. Again, apologies for taking so long to unmute. I'm going to hit my computer with a stick. Any questions or comments for Jenna? I don't see any, so that's great. Thank you very much. Forthcoming board programme is there to note. And I think that just about brings us to the end of this morning's agenda. I haven't been notified of any other business that colleagues might want to raise, and I don't have any other business. Thank you very much, everybody, for your attention and contributions this morning. That's been, I think, another really helpful set of conversations framed by a really useful board story, and as colleagues I think noted at the beginning of the meeting, it's really good to hear about the positive impact our services have on the lives of patients and service users. We've had in the last year some really difficult patient stories to hear, but it's nice to see those in context and to remind ourselves that very often we get it right, and so that was you know, I think a really important story from that perspective, and a really good opportunity to thank a staff team that are clearly doing an excellent job. So I'm going to bring things to a conclusion. Thank you very much, everybody, and for those of us moving on to private board, we've got a training session starting at 11:30, so I will see you then. Thank you very much.